Testing, testing. 1, 2, 3. Testing. 1, 2, 3. Testing. 1, 2, 3.
Hello. Can you hear me, Anna? All right, good to go, I think. Thanks, Anna. It's like it sounds like 8 seconds or so. Okay, cool. I'll text you. I'll text you in a bit. Okay, bye. Okay, I think we'll start in just a couple minutes. Let's give it a minute, and then whoever is leading. But it looks weird.
Why is everything yellow?
Oh,
there you
go. It is kind of funny.
Yellow goes.
I gotta do like something like this.
Then we were hoping that one of the residents could just monitor. Ask something. I'm not gonna be able to pronounce it. So, and then
I know.
I will give you a mic.
There we go. Don't touch it. Okay, let's see if this even made a difference. Yay! I did it. It worked. Oh, thank God.
Oh, cool.
Yeah. Okay, I'm gonna download my. It's on it. And I lost it too.
They all.
Oh, she didn't need to be switched. Maybe it's that.
Maybe it's that. Oh, okay. You gotta download it. Hello. I hate this. Got the green hair. Hello. Oh, there it is.
Yeah. See there? Hello. When I plug it in, dude, this mic, can you make that work? That will be the speaker.
Turn that off.
Oh.
Just press it. Oh, yeah. Just hold it for like 3 seconds. Yes, when it breaks.
So I guess you don't have to be so forceful with it.
Did you say hello?
And you need that green.
Oh, okay. So it's like all
Yes,
good.
so you're on now. So you could.
Cool. All right. All right.
This working? Yes. Good morning, dermatology, and welcome to our first hybrid grand round since the pandemic. Hooray! We've got a few things to discuss before we get into cows and presentations and so on. So let's see, the department asked me, well, Shantae asked me, I assume she was acting on behalf of the department, to make a few announcements. To make it more exciting, I have sprinkled in one of my own announcements that's false, so you guys can decide which one of the following is untrue. Announcement number 1 is that the department has contracted with a courier service to deliver bagels and coffee to all of you at home. Announcement number 2 is that hopefully you have noticed that we're not using Zoom today, so if you're on Zoom, you are not hearing me. We're on the Ustream, which is apparently what we used to use, and the change is, because this is supposed to be better in terms of audio and visual capabilities for those of you attending from home, but there is no audio function, so attendees can't sort of speak their questions or thoughts, but there is a chat function, so please use that. Dave Sani will be monitoring the chat, and will let the rest of us know what you guys all think. So there are no physical patients here today, so those of you at home didn't miss out, but we are hoping / planning, I don't know if there's some already scheduled. Shantae says yes, on July 9th, which is our next grand round. So an extra impetus to come in person on July 9th. Those of us hosting or presenting will be expected to be here in person, so please plan on that. And then again, July 9th here in classroom A. Today's event code, by the way, is 169020. That is 169020. And before we talk about cows, Dr. Duffy has an announcement.
So this is a sad day for me because Alice is our first fellow that I've had the pleasure of training, and this is sort of a tribute to Alice. We've got a couple of weeks left with her, but it feels like the end of the road here. We had a lovely dinner last night at Finca. Thank you, Amanda, for arranging that. It was a really good time, even though Fred drank all of Alice's rosé. It was still a good night. So let's just pull that up there. Let's go back to the beginning. So I don't know how long this is. As I just started getting, I just kept adding photos. So I don't know. It could be 5 minutes. It could be 10 minutes. I'm not sure how long it is. Thank you. And then advancement-wise is just this. So it was an exciting year. It took us a while to get this fellowship going. Personally, it's been really fun. I mean, you get to kind of be like mid-career, and it just gets to be going to work every day and putting people back together. But then, coming to work and, watching somebody sort of struggle with a flap and what to do. And it's really kind of fun to just watch the progression of fellows go through things. So it's, it's a little bit bittersweet, right? I mean, we're at that really sweet spot right now where Alice can just run the clinic. But it's going to be fun to see our next fellow, next year kind of progress in the same way. This is our first fellow since Dr. Glenn Bowen and Dr. Payam Tristani were fellows in the early 2000s under Dr. Gerwells. So this is the first ACGME approved fellowship. Those were ACMS, Mohs College fellowships. So Alice is really our first University of Utah fellow through the ACGME. I don't need to go into her long background, her history. She's a self-reported PGY 12, I think. Is that what you said, Alice? So, Alice started in medicine in Milan, so completed medical school there, completed a maxillofacial surgery residency in Italy, got a PhD in physiology, and then came to Harvard and worked on some devices as well as doing some vascular anomaly work. And then, as twists have it, she does an internship in pediatrics of all things, really just to sort of challenge herself, I think. And then she, did an outstanding job in our residency, and then has done an outstanding job this year as our Mohs fellow. And it's very sweet of her. She, we were in the OR the other day, and she said, "I wish I could just stay for another year." And that was like very Alice to say something like that, no, I want to make $65,000 for another year. This is great. This is the first day of training. This is up at the Huntsman. You can see we have Glenn's coat in the background here. You can see at this point, there's sort of nothing there, right? I think this is actually the first case you grossed in, Alice, at the Huntsman, doing slow-mos. So you can see her enthusiasm even under that N95 for what she was doing. So she's had a lot of work doing melanoma in situ, and she'll continue doing some of that with us at the Huntsman. This is my thumb on like July 6th. So I was camping and got my thumb caught in a camping trailer and broke my right thumb right at the beginning of Alice's fellowship. So she was really just, right out of the gate, because I couldn't suture for like 2 or 3 weeks. So Alice was pretty much thrown right into the fire. in terms of clinical work, and did a lot of good directing. This is just Alice and Amanda doing a scalp flap in clinic. And I figured I had to throw in a couple of photos of some of her repairs. This is a squamous cell carcinoma on the cheek. And, you know, it's always fun to watch the fellows go and perform and do these flaps. And, you know, this is her undermining it. And, you know, they think they look kind of horrible, you know, when they're done. You go, is that going to do okay? Alice, perfect. It looks great. You did a great job. And must already flap, patient comes back. So, you know, really nice repairs through the year. This is Alice doing I think this is a lip wedge with Gabby. You kind of see she's standing a little further away from the table at this point. So it's progressing through the year a little bit. COVID was just weird, right? I mean, we were gowning up and wearing all these funny things and N95s, and I forget what we were swabbing. We were swabbing somebody for COVID this day in clinic, and just a weird year. And so it'll be even more memorable, I think, for Alice and I, because of the weirdness of COVID. Even the staff got a little weird through this whole time. And this I just wanted to point out, this was a really fun thing we did during the fellowship. We asked everybody in Mose to submit their 5 songs that they would take to some deserted island. If you could only take 5 songs, these would be the 5 songs. And then we had a day where we kind of played all of the music. And we had over 100 songs that were collected. And the really interesting thing is that in all of that, nobody picked the same song. So everybody picked 5 different songs in a group of 20-something people to take to this, you know, desert island. So this is just kind of a list. Everybody just kind of handed me their songs, and we put it together in a Spotify playlist. These were Alice's songs, just so you know which ones Alice picked. She kind of ran out of clinic and didn't hand it to me, and then, you know, I texted her. I said, I need those songs like tonight so I can put this together. And so these are Alice's 5 songs, which I think is an outstanding list, actually, of songs. So I never knew she was such a Dire Straits fan, and we listened to a lot of Dire Straits this year, which was great. And this is some more pictures. So this is Chloe and Alice scrubbing. I don't know if you guys are aware, but on Wednesday afternoons, now once or twice a month, we're taking patients to the OR to do some larger procedures that require general anesthesia. So get in touch with Alice or I if you have patients that you think might benefit from this. You can kind of see she's standing a little bit further from the scrub sink here too. And then just a couple of pictures of Alice in the moment here doing some repairs. This was something from Adam Tinklepaw, which was in his clinic and referred to the OR for a forehead flap. Kind of a nightmare case here, soft triangle involved, et cetera. So Alice put a nice forehead flap on this gentleman, and this was about 8 hours later. So it's clearly the biggest clot I've ever seen post forehead flap when he came in. I mean, I didn't even have to like blot his eyes out because the clot is like covering his eyes in this. But he did great, right? This is his repair. This is his nose now. So, you know, a really nice job on the forehead flap, even though we had that small complication. But that's part of the fellowship. You get to learn how to manage these types of things. And then we had baby Gigi, baby Julia, April 14th. I got that right, Alice? Yeah. So she arrived on April 14th. What a little peanut, so cute. And Fred and Alice are beaming, as you can see. This is like this is one of the cutest pictures she texted me of the baby and her dog. I mean, look at the look at the dog's face. It's amazing. And then this was a great one that she texted me too, using her loops to cut baby Gigi's nails. So, and this was our last day. The other day in the operating room, she's become quite the expert with genital cases. So you can refer a lot of your genital skin cancers to Alice. Yeah, we've been doing a lot of extra mammary pageants in the operating room. And this is, just the last fellow Dr. Frigerio thing. She'll be the attending next year, and makes me sad and happy all at once. So, bravissima, Dr. Frigerio. So we don't actually have your diploma yet, but here's what it can go into when we actually get it at some point. So come on up, Alice.
Oh, thank you.
And then I'm sure Fred's going to hate me for this, but that's okay. So I bought Alice some vinyl.
Oh, fantastic.
And then, of course, you need something to play vinyl on. So, I bought her something to play the vinyl on. So hopefully she'll start her vinyl collection with this. Thank you, Alice. It's been so much fun. And the great part is we don't have to say goodbye. Alice is staying on. She's going to be working with us, doing Mohs, doing some vascular anomalies at Primary Children's, continuing to do some research. So we don't have to say goodbye. It's just, it's basically welcome.
That's true.
Okay. Thanks, Alice.
Thank you, Keith. Just a minute. I wanted to say thank you to everyone for giving me this possibility, and well, it's been a great year. I'm very grateful for this fellowship, and Keith has been an incredible teacher and mentor and friend. You've been very generous teaching me all what you could in the field of dermatology, Mohs surgery and dermatopathology. I feel like I've become very confident and comfortable with cases. And I've enjoyed going to the OR together and doing cases together. You're someone I can say, let's get that, we need that instrument, and you think that's a good idea. So I feel like we have had many things in common that we have enjoyed sharing, and it's been a fantastic year. And also I've enjoyed working with all the other faculty members of the Mohs Fellowship who are not here today in person, and I would like to say thank you to all of them too.
And I think we're going to move on to the cow. Is that right?
Yes.
All right. Thanks, Decker.
All right. So I have a cow for you all. We have an 81-year-old female who was seen in the outpatient dermatology for chronic ulcers on her left digits. They affected both the left second and fifth digits. Started about 3 months prior to presentation. She first presented in March. and developed after laceration from a knife. Ulcers were painful, but patient denied any purulent discharge. She had a culture in April, which was positive for yeast. It was unclear if patient was treated with diflucan, but that was in the plan. Anyway, she was on levofloxacin for treatment of UTI, and she endorsed improvement of these ulcers while on this antibiotics. She was treated with Vaseline, vinegar soaks, course of Keflex, debridement, Lidex ointment with no improvement. She had a fungal culture in May that grew Candida tropicalis and Candida albicans, and then she had a repeat aerobic culture which grew Pseudomonas, Stentrophromonas, and MSSA. She was treated with clotrimazole cream with little improvement. As far as her pertinent past medical history, she has chronic kidney disease on dialysis, hemodialysis 3 times weekly for 7 years, and she has a left brachiocephalic fistula that was created in 2014. Interestingly, when you look at the vascular surgery notes about 5 years ago, patient said that she endorsed pain at the fistula and the distal forearm during dialysis. She also has diabetes type 2, coronary artery disease, hypertension, hyperlipidemia. As far as review of systems, it was normal. And so we see here on the medial aspect of her DIP joint on her left fifth digit, she has this about 1 centimeter ulceration with the overlying yellow eschar. And on the right, you see on her left second digit at the proximal lateral nail fold, she has about a 4 millimeter ulceration, again with this overlying yellow-brown eschar. So these pictures are taken, she was seen on a weekly basis, and you can see that here, you know, her ulcer didn't really improve. So this picture was taken at the end of May, and you can see here, similar size ulceration, but now with firmness base or surrounding erythema. And she saw our fabulous dermatologist, Dr. Marta Peterson, who looked at her pulses, and she noticed that her left radial pulse was 1+, and her right radial pulse was 2+, dorsalis pedis pulses were 2+. No carotid bruits were noted. And so she, was curious about, this brachiocephalic fistula was in the same hand where these ulcers developed. And so she referred the patient to vascular surgery for evaluation. And so vascular surgery did a workup, and they did this evaluation called photoplethysmogram, or PPG, which uses a pulse oximetry to detect blood flow to the digits, at the digits. And you can see it in this image on the left. Here's the right hand, and here's the left hand. And these are the waveforms that occur when, the heart pumps the blood. And you can see here, first digit, second digit, third digit, fourth digit, fifth digit, all normal waveforms. But if you look on the left hand, the fifth digit has diminished waveforms. They do a test where they compress the fistula, and then they'd also detect the blood flow to the fingers. And you notice here on the left fifth digit, there's an increase in the amplitude in this waveform in the fifth digit. And so this finding is suggestive of vascular steal, arteriovascular steal syndrome. So they did an ultrasound, and what they found was that the ultrasound had increased flow in the fistula compared to previous images. There was antegrade flow distal to the fistula, no retrograde flow. And so this is a case of distal hypoperfusion ischemic syndrome, or also known as arterial steal syndrome. The incidence of this condition is 1 to 8% in patients with hemodialysis access creation. It's more rare when the fistula is at the wrist, but more common in brachial artery fistulas, about 5 to 8% incidence rate, which our patient had. Risk factors include female gender, greater than 60 years of age, previous operations at the same limb, and again, use of brachial artery as the access donor vessel. So the clinical presentation of SEAL, there are acute symptoms and there's chronic symptoms. Acute symptoms present immediately after surgery, and you present it with a cold, white, or bluish painful hand, which requires immediate correction. Chronic occurs weeks to months after placement. It's often progressive, Early symptoms are mild self-limiting, but late symptoms are associated with ischemia and are progressive and require surgical intervention. And so here's a table on the right showing the Steele symptoms in order of increasing severity. So you can get nail changes, occasional tingling, extremity coolness, tingling and numbness in hand and fingers, muscle weakness, pale to whitish or cyanotic finger beds, rest pain, sensory and motor function deficits, fingertip ulcerations, which our patient presented with, and then unfortunately tissue loss. And so chronic Steele may be evidence after an unrelated minor trauma when a fingernail or fingertip becomes a non-healing infection as seen in our patient. So here are examples of Steele syndrome resulting in finger ulcerations and infection. And you can see A and B, again, the proximal lateral fold, you see this, ulceration with overlying eschar. C is they removed the nail and they treated the fistula with banding and the ulceration resolved. D is an example of a non-compliant patient with diabetes who also had Steele syndrome, and you can notice the multiple ulcers at the digits. You can get nail changes, as I mentioned. So A is with a patient who had brachial fistula, and these are the nail changes that were in that same extremity, and B is the patient's other extremity, and you can notice the difference in the nail changes. C is example of dry ulceration at the fingertips, and then D is an example of tissue loss. So physical findings associated with this syndrome is diminished or absent radial pulse, and ulnar pulses. You have relief of symptoms when compressing the AV axis. You can see ischemic changes, as I mentioned, brachial artery digital index of 0.6 or less, digital pressures below 50 or non-recordable, and then abnormal waveform suggestive of Steele. And again, on the right is we have this device that measures finger pressure measurements and waveform evaluations at the digits. And in picture B, you can see they have a little pressure cuff that you put around the base of the digit. And then this device at the tip, this rod, is the PPG, and that detects the blood flow to the fingertips. And so in picture C is a picture of normal waveforms of a patient, and then D is a patient with Steele, and you can see there's diminished, amplitude of the waves. And E is the compression test, and you can see there's an increased amplitude of the wave after the compression. The cuff, I think, detects the pressure of the blood flow, and then the rod detects is the pulse oximetry, and it detects the flow to the tip. I think, I don't. I think what's just displayed is the PPG, yeah. So, you can also get an ultrasound. You can, evaluate how much blood flow is going through the fistula, if there's any aneurysm at the fistula that may be contributing to the Steele. And it is recommended if a patient, requires surgical intervention that they get an angiogram first. So you can diagnose and treat any microvascular occlusion that is there with balloon angioplasty. So the treatment of Steele, if it's mild, you can have you just observe, but there are several surgical interventions. You can get partial banding of the axis conduit, and so what you do is at the mid portion of the fistula, or you decrease the diameter of the fistula, and so that should shunt blood to the distal extremities and from the fistula. You can do this distal revascularization and interval ligation, which is depicted on the right. Our patient is being considered for this procedure, and what happens here is you get a vein graft, and it's usually the saphenous vein, and you attach it proximal to the fistula, and then you attach it obviously distal to the fistula, and at the distal artery proximal to the connection, you ligate the vessel so that it prevents retrograde blood flow back to the fistula. And then eventually you can ligate the AV axis. And so we just wanted to present this case, it's an interesting case. And also just, we wanted to question the derm surgeons. Every time, should we do, is there any pre-op evaluation that needs to be done, if we're considering doing a procedure on a patient who has, a fistula placed, just in case, does it promote delay wound healing, et cetera? . . . . . . . . . . . . . . . . . . . . . . . . . . . . . . . . . . . . . . . . . . . . . . . . . . . . . . . . . . . . . . . . . . . . . . . . . . . . . . . . . . . . . . . . . . . . . . . . . . . . . . . . . . . . . . . . . . . . . . . . . . . . . . . . . . . . . . . . . . . . . . . . . . . . . . . . . . . . . . . . . . . . . . . . . . . . . . . . . . . . . . . . . . . . . . . . I don't know the answer to that. They do, I think it depends on, I don't know the exact reason, but they do detect, they look at every digit, and I think it varies. I don't think it's just specific fingers, but I guess whatever. There's could be contributing factors too. So these patients tend not to be healthy, and so there might be, atherosclerosis or whatever that's preventing, blood flow to those areas. Oh, okay, sounds good.
Thanks, Abram. Really cool case. And I believe Dr. Duffy has said in the past that if you include a radiographic image in your dermatology presentation, you've got a good chance of being accepted to a conference. If you manage to include some plethysmograms, you've got to be an auto-accept, I would imagine. So so for those of you at home, again, the event code is 169020, and after our presentation, I think we have 2 patients to discuss. Our presenter today is Dr. Decker Deacon, one of our senior residents, who in a couple weeks will be joining our faculty, unless he really screws up this presentation.
No pressure. Well, now that we're back here in person, there's no more opportunities for technical mishaps, so we should be good. Okay, so I don't have any conflicts of interest with respect to this presentation. I hope to at some day, but not yet. I feel like any good presentation of someone working on something, they do have some disclaimers. There's our CME code again, and our learning objectives. So today, I'd like to review some key decision-making points in clinical care of melanoma patients, discuss theoretical framework for biomarker utility analysis, explore the potential utility of biomarkers in key decision points, and review the current state of commercially available biomarkers in the context of this framework. And I guess the one disclosure that I should make, though, is that if you'd prefer, you can tune out now and just read the review article that we published in April. I think this format will lend nicely to kind of a discussion and back and forth as to how these might be useful. But if you're more of a read it on your own person, you can wade through the 26 pages of this manuscript on your own. I'd like to thank Rob and Eric Smith. So Rob is in our department here. He's faculty. I'll be working with closely next year up at Huntsman, and Eric is a pathology resident who's looking to go into molecular pathology. And we worked closely on this paper together that's out now. Okay, so the first clinical question in melanoma diagnosis and treatment, the one that we're probably most familiar with in this room that I think is amenable to a molecular biomarker, is deciding whether or not we're going to biopsy something. For the most part, when someone comes into clinic, you're making this decision based on history and physical exam, but we'll get into some interesting points about how a biomarker could be helpful in this process. Second key point is once something's been biopsied, and it's not clear-cut, either benign or malignant, you end up in this kind of intermediate melanocytic proliferation range, and the pathologists have to decide, is this benign, don't do anything about it, is it kind of atypical, maybe do a conservative re-excision, or is it definitely malignant, and you should cut it out. And then the third major branch point I want to talk about is prognosticating whether a melanoma is of high risk of metastasis. So once something is histologically, or you've decided that this is definitely a melanoma, is it likely to go on to do bad things as a melanoma? And that may inform whether you treat this just with a wide local excision, or if you do a sentinel lymph node, if you decide to add on sentinel or adjuvant therapy at the same time. So that's another branch point of uncertainty in the care that is amenable to a biomarker. And here's some examples of commercially available tests to address each of these questions. We'll get into these more a little later. So once When we were invited to write this review article, we were told we should chat with Bob Schmidt, who's over at ARUP and helps run their system for deciding on validating new tests that they offer at ARUP. And he has this great lecture. It's about 20 minutes if anyone's interested in this. I've got the URL up here. On testing a test, so deciding when a test is useful and in what characteristics it is useful. And we use the framework that he described in that talk to kind of go through each of these branch points systematically. So basically, when you should only order a test when you have a situation of clinical uncertainty. You're never going to order a test, or I hope you're never going to order a test, if you know what you're going to do, regardless of the result of that test. You're ordering a test because you're not sure what's going on with some sort of clinical question. And the idea fundamentally with a test is that you have your kind of prior odds of, in this case, a disease state as just 50-50. And then you do a test and that changes your odds to, in this case, about 5-fold more likely that that disease is there than it was before the test. And so tests can be useful in two different ways. One is moving you from a state of uncertainty to a state of positivity. You think that that disease state is there, you're confirming that. And the second is to exclude it by saying that test is negative, and it's negative to a degree that I think that that disease state is no longer there, and I'm not going to worry about it anymore. We're not going to pursue some sort of intervention. The degree of positivity or negativity in your confidence, we call a likelihood ratio. So that's the LR plus and LR minus. And that basically says how much more confident you are in your prior odds based on this test to get to your posterior odds. So this is the format we used in our paper, and it's pretty similar here, but we've modified it a little bit. So you've got your decision thresholds here, and you could consider like to biopsy or not to biopsy, or to do a sentinel lymph node, not to do a sentinel lymph node. And these numbers can shift based on your patient, your clinical risk tolerance. But the idea is that you start off at some prior odds and you end up at some posterior odds via a test. And the reason this is important in laboratory study evaluation is knowing whether a test is going to be useful at a population level. So in terms of, you're all familiar with sensitivity and specificity. Those are kind of some statistics that we use frequently for determining whether a test is going to be useful. And these likelihood ratios of the positive result and negative result actually correspond to the slope of, this is a receiver operator characteristic test curve here. And those likelihood ratios correspond to the slope of your curve at each point across here. And the reason we do these ROC curves is because when you're setting a threshold for a continuous variable on a test, you can move your sensitivity and specificity based on your threshold, and the AUC curve helps kind of aggregate all of that into one score that you can compare tests to different tests. So in blue here, we've got the area that a positive test might be useful if your LR plus, I'm sorry, I'm pointing at the screen with my finger. I should be using the mouse here. If your LR plus needs to be at 10 to get to your clinical threshold here, your decision threshold, then this is kind of the area in which your ROC curve would give you a valuable test. And similarly, if you need a 10-fold decrease in your likelihood of, in your posterior odds, you would need this LR of 0.1, and this is your valuable test area. So these are basically what I'm trying to say here is that there's a wide breadth of understanding between people ordering tests and people validating tests. And what we're going to get into here is that some of the clinical situations that we would be using these tests in have kind of unique utility parameters where they would be useful or not. Do we have any questions at this point? Because this is kind of the foundation of everything else we go through. So the prior odds is your assumption before you do the test, and the posterior odds is after you do the test. Yes.
This is really basic, but why do you start at the 1-to-1?
Yeah, good question. So the question was, why are we starting at 1-to-1? This is an example to start getting us primed, but that number will move based on the scenarios we go through, and then also your assumptions for each individual question that you're looking at. You will have a different prior odds. So if you're really sure that something is a melanoma, you may have a 10-to-1, 100-to-1, 1,000-to-1. If you're really sure something is not, you would be higher up on this spectrum of less likely to be. Yeah. That will change. So your starting point will change the angle necessary for your test in order for you to cross your decision-making threshold. One more question. You could, so pre-test and post-test probability, like positive predictive value, or I guess, yeah, pre-test, post-test probability are essentially the same thing. Yeah. Okay. So getting back to that first decision point, someone walks in, this spot on your arm, they say it's new, it's changing. You think, okay, that's a little atypical. Maybe I'm not super concerned about it, but with the history they're giving me, I think I'd probably want to biopsy that. So, Steph, to your question, we're not starting off at 1-to-1 here. We're thinking this is more likely to be a melanoma than 1-to-1, but maybe still, you know, it's not that atypical. Maybe it's kind of in this territory. The threshold to biopsy, yeah, based on how many malignant things people biopsy, your number needed to biopsy. I estimated that people will biopsy about 100 benign melanocytic neoplasia for every one malignant that they biopsy. That's not actually what the data would say. The data would say your threshold is maybe a little lower, but this is a pretty conservative threshold. And even with that conservative threshold, if your prior odds are in this territory, you are going to biopsy this even if your confirmation test is flat. It doesn't give you any additional information. That's an LR of 1. You would still elect to biopsy. So effectively, there's no test that's going to tell you you should biopsy something that you already think you're going to biopsy. And that goes back to one of our key points of don't order a test if it's not going to change your management. And that test would not. But if you say this was on someone's nose or ear and they were worried about it but didn't want it to be biopsy because of the site, you could consider with this kind of prior odds a scenario where you were able to do a test to rule out a biopsy. And if that gave you a higher degree of certainty, like a 10-fold odds that this was not malignant, that you might cross your decision threshold and avoid a biopsy. That is in contrast to if something like this walks into your clinic, and we saw this one on Tuesday, Steph, your prior odds that this is a melanoma are 1 million, and there's no test on the world that is going to change your decision of whether or not to biopsy this. And so even if your LR minus, or your likelihood ratio, your negative likelihood ratio is 0.0001, you're not going to avoid a biopsy on this case because your prior odds are so high. So kind of understanding what your starting point is and the limitations of your test can help you decide when it's appropriate to order a test. So basically for this, the summary is with a single lesion, a kind of unusual clinical presentation, you're pretty much always going to biopsy, except in very certain limited situations. And so you could use a test at this stage clinically if you were trying to rule out a biopsy, but not a whole lot of utility in ruling it in. And that's what is shown here on the bottom right. However, so that's with a solitary lesion. With multiple lesions, the calculus kind of changes. So this is a patient of Doug Grossman's that he published a couple of years ago now, who had a history of 9 melanomas, came in with 20 plus clinically atypical melanocytic proliferations. He did this DermTech tape stripping analysis on 20 of these areas and identified 6 of these as melanoma and 14 of which were negative with this test, and was able to avoid 14 biopsies and only biopsy the melanomas. And for this, your thresholds before and after might change. But for those patients that really want you to only biopsy a couple spots, your dysplastic nevus patients who have gone through dozens and dozens of biopsies and excisions for dysplastic nevi and are tired of it, this might be a useful situation to order these tests to help prioritize what you're going to biopsy going forward. And that's reflected here in the receiver operator curve graph, demonstrating that there's more space that's highlighted here for a potentially useful test. So the test doesn't have to be quite as good in order for it to be useful in this situation. So just highlighting again that there's specialized circumstances in which these can be useful. Okay, so now getting into the second, I want to make sure I have enough time. About 15 minutes probably good for cases. Great. We've got, so after you've biopsied something, if you have an intermediate melanocytic proliferation, our dermatopathologists are trying to decide whether to call it, truly malignant, or is it atypical, I don't like it, but I can't really get to melanoma, but you should probably cut it out, or is it just something that's benign? You may not be familiar with the empath DX classification system, but this is what is at least used in publications for showing which diagnoses within the melanocytic spectrum, kind of categorizing those a little bit. In class 1, 5, and 1, 4, and 5, there's really high levels of congruity amongst pathologists in terms of diagnosing things reproducibly. But in this 2, 3 area, so that's moderately atypical dysplastic nevi, some spindle cell nevi, some Spitz tumors, melanoma in situ, atypical melanocytic proliferations. Those are kind of the gray zone of our histopathologic diagnosis spectrum in melanocytic tumors. And that's where a biomarker is more likely to be useful, is where there's greater degrees of uncertainty at the beginning. And so going back to our framework here, those empath class 1, the definitely benign type stuff, there's no test that's likely to change management. This could be a million, but if it's a clear-cut benign mole, no one's going to even order that test. And same with an obviously invasive malignant melanoma. There's no test in the world that you're going to order that says, it's 1,000 times less likely to be melanoma than you thought it was before, but it was still a melanoma to begin with. You're still going to go ahead and treat that as a melanoma. But this gray zone in the middle, the class 2, 3 lesions, those are ones where there's some variability in whether you're going to treat it with 5 millimeter margins, 10 to 20 millimeter margins, or just observe and not do an excision. And those moderate to severely dysplastic nevi or atypical melanocytic proliferations that we treat with 5 millimeter margin excision right now, you could imagine a test, and your values may vary in terms of your likelihood ratio of where you would need to get to in order to say, I'm just going to monitor this. But a test could be valuable in that situation for saying, I don't need to excise this, or I am going to excise it with larger margins. And a pretty good availability of test characteristics for that clinical situation. And then getting to this last one that we have a decent amount of exposure to in dermatology is deciding whether or not someone should undergo sentinel lymph node biopsy. And with the AJCC 8 criteria, we mostly just say, okay, it's Breslow 0.8 or more, you're going to Surg-Onc, and you can decide with them whether you're going to get a sentinel lymph node. But in discussing this with patients and sending them there, we do have kind of a role to play in determining counseling patients on that decision. And also, some of these companies that are marketing these tests right now are marketing them towards dermatologists. So I think it's important to be aware of what you're getting into if you're looking into ordering any of these tests. So there's a high degree of uncertainty in this Breslow range of a T1B melanoma, where it's about 1 in 20 are positive, and so the surgeons will only do a sentinel lymph node biopsy if they think that there's less than a 1 in 20 chance or a 5% chance that a patient will have a good surgical outcome. But basically that's to say there's a high degree of uncertainty as to who's going to be positive in this range. And so testing that is able to discriminate even with a small nudge in either direction of whether someone is going to be positive or negative could have a big impact in clinical care. And then as you get less and less invasive with the T1A and melanoma in situ, you would need a higher likelihood ratio to indicate you should do a sentinel lymph node biopsy. And where this is really important is more people die of metastatic melanoma from melanoma in situs and T1A melanomas than T1B plus melanomas, which is kind of surprising. Like, why don't we do sentinel lymph node biopsies for those earlier stage patients? And it's because there's a lot more of them and the likelihood that they're positive is a lot less. But there are definitely some people in this T1A and melanoma in situ range who would benefit from a sentinel lymph node biopsy at time of wide local excision. And it's the majority of patients who die with melanoma are in this range. So there is definitely room for improvement in that clinical decision making. And this is going through, again, it would have to be a really good test to show that you should do a sentinel lymph node in a melanoma in situ, but that kind of decreases as you get more and more Breslow depth. And then when you get to the T1B, really, it doesn't need to be that great of a test to have clinical utility in terms of its sensitivity and specificity, because you're starting off with such a low level of certainty to begin with. Okay, and then looking into advanced melanoma stage 3, 4 biomarkers. This is mostly the realm of medical oncology, but there's some interesting up and coming stuff in this realm as well. So some serum-based studies for evaluating disease extent and progression. So that's things like circulating tumor DNA, circulating tumor RNA, disease-specific mutations identified in the blood, and circulating tumor cells are all things that can be monitored relatively non-invasively via peripheral blood that can be useful in determining both disease burden, treatment efficacy, treatment response, relapse. And so people are studying, and there's a number of clinical trials ongoing right now in that space. And then this is something that's already going on that you may not think about as a biomarker, but targeted inhibition of these various pathways that we have targeted inhibitors for is something that's already incorporated into the NCCN guidelines, and is actually the only part of this talk that is NCCN guideline written into those guidelines. And then one of the most important things that an immune checkpoint inhibitor or what a biomarker could be used for is in determining immune checkpoint inhibitor response. So immune checkpoint inhibitors have really revolutionized our treatment of advanced stage melanomas. They work really well in some patients. And so on average, it's a really significant improvement over our prior chemotherapy and interferon regimens. But knowing which patients are going to respond to a multi-tens of thousand, hundreds of $1,000 drug with all the potential side effects of that, and which ones are not going to benefit from that before embarking on that process is a really important question that could be addressed with biomarkers as well. People are actively working on that. Okay, so this is probably, if you had to remember one slide from this talk, it's either going to be this one or the next one. So get a big drink of coffee and listen up. So these are some of the major tests that are being marketed directly to physicians at this point for use in deciding whether to biopsy something. That's the DermTech pigmented lesion assay, the Myriad MyPath melanoma, which was recently acquired by Castle Biosciences, and then the Decision DX gene expression profile test, which is also owned by Castle. So the major pros for the DermTech test, and these are my pros and cons. You can use this on multiple lesions. That's the kind of clinical scenario. That and avoiding biopsy in sensitive areas. Those are when this is going to be the most useful test in our current situation. The cons, it takes a couple days, if not a week, to get the results of this back. And so rather than seeing someone biopsying it immediately and having your answer, your histologic answer in less than a week, you have to do this test. It takes about as long as it does to do a biopsy, and then get the results of it. And then if it is positive, bring them back. So you kind of have to think about, is it worth it to go through that whole process, or do you want to just biopsy it up front? And it's not for use on acral sites. The Myriad MyPath has, I think one of the pros of it is, oh, sorry, go ahead, Steph.
I just really like the point you're making about the really like financially possible, or
Yeah. Good question. So question is, how financially feasible is it to do this on multiple lesions? The CMS reimbursement rate for this is about $760 per test. That's for the first one, and then each subsequent one is a lower reimbursement rate. DermTech has it set up so that it is reimbursed by most insurances. And there have been a couple of studies that say it is cost effective compared to biopsying everything with the downstream implications of that. I think it's probably pretty equivocal or close to equivocal in terms of doing this test versus biopsying straight up.
One more follow-up question.
Yes.
Are there any studies that put this together with like confocal microscopy or something else like that that would improve our sensitivity?
Yeah, the question was, are there any studies that use this DermTech tape stripping test in conjunction with dermoscopy or confocal microscopy to improve care? And not that I'm aware of. I think all of the tests that have been done so far have been in the absence of those techniques. You would think that confocal or dermoscopy with a trained person would add to that sensitivity and specificity of this. The exact test characteristics of this test are pretty good on their own, at least in terms of you can be over 99% sure that if the test is negative, that it's not a melanoma. The problem with dermoscopy and confocal is that they're both user operator dependent and require a lot of training. And one of the advantages of tests like this is that this could be applied in primary care in rural Wyoming by someone who's has no training and no specialized expertise, and is objective in the output as opposed to confocal or dermoscopy. And so that's another advantage of these genetic biomarkers. Yes, Nisma. The light is red, so.
I was just going to say, oh, there it is.
There it is.
I was just going to say that I actually spoke to the people at Castle about kind of like feasibility and affordability of this test. And I don't know if this is true, but per them, they said that if insurance doesn't cover this test, they won't make the patient pay. So it'll be whatever the insurance will cover for the test. So as of now, because they're trying to get more data, would be the best time to try to use it. And then probably as it becomes more mainstream in their thought, it's probably going to get more expensive.
Is that for MyPath or for Castle?
For Castle. Mm-hmm.
The 31 GEP for sentinel lymph node or distant metastasis free survival. Okay, so for MyPath, I like how it's limited to dermatopathologists. So not just anyone can order it. It's only when the dermatopathologist is really concerned that it's atypical and borderline. And they've done a really excellent job in terms of their validation data. They're the only group of all the 100 plus papers that we analyzed for this study, the only ones who looked at long-term clinical outcomes and used multiple dermatopathologist consensus, did head-to-head trials of certain techniques. They really did a great job of trying to validate this in what is otherwise a very challenging field. The cons is that some of those head-to-head tests indicated that maybe FISH and CGH or genomic variability might be better. Okay, and then the Castle Biosciences 31 GEP called Decision DX really does address a critical point in our decision making of whether or not someone should undergo sentinel lymph node biopsy. The downside is this is not integrated into NCCN guidelines. It is FDA approved, but it's not integrated into these guidelines because there really isn't enough data to show that this test adds anything above and beyond our AJCC criteria. And that's largely because when they did the analyses for these, they combine the substages, so like 2A, 2B, 2C melanomas are all combined in those analyses, and they refuse to break out the data and really let us determine how this test performs against that. Nisma has a question.
Not a question, but Dr. Curtis was just saying DermTech won't charge the patient either.
Oh, great. So Dr. Milliken warns us of the dangers of these so-called free tests that will eventually get passed on to your insurance costs down the road. And I do agree with that. There have been several financial analyses of a number of these tests that show that they have the potential, at least, to decrease costs overall, and if that's in avoiding unnecessary excisions and other downstream testing. Okay, so this is from Doug's paper on the melanoma prevention working group, kind of outlining the level of data for these prognostic gene tests, and also our paper looking at some of these biomarkers in histologic diagnosis. And the take home here is people have done a lot in terms of trying to figure out the best way to validate these. It's still very challenging. We didn't find any papers that had been rigorously validated, and the melanoma prevention working group kind of also came to that consensus agreement as well that none of these tests are really ready for prime time yet outside of a clinical trial or a multidisciplinary group. Okay, so our final take-home points here, and then I think I have to turn this over for patients. Understand the limitations and potential outcomes of a test before ordering that test. Think about what you will do with each potential test outcome and only order tests that have the potential to change your management. If you're ordering a test because you're hoping that it's going to be negative, but then it comes back positive and you end up in a bad situation, we see that fairly frequently at Tumor Board, that's not where you want to be. The circumstances in which these tests should currently be used is limited right now. Some special patient circumstances that we talked about and as part of clinical trials are multidisciplinary treatment planning conferences is really the consensus of the melanoma prevention working group. And then more tests are coming. So genetic tests are getting cheaper. People are trying to apply them to more and more things. I am guilty of this as well. I'm trying to develop biomarkers that I think could be clinically useful. I think there's a lot of promise in this. I think eventually it could lead to improved care and decreased costs and better all around. But you are going to be responsible for interpreting patients who come to you with these tests already ordered, and I would steer you towards the NCCN guidelines initially because they're updated pretty frequently on this, and I think very comprehensive. I'd like to thank all these folks who helped out with this paper and this work. And if you have any pressing questions now that we haven't gotten to later, or if you want to email me, or if you ever have patients who come with their own genetic testing and want some help interpreting it, I'm always happy to help out with that. Great. And episode 52 of the Dermosphere podcast, if you want to listen to it more.
All right, how about another round of applause for Jacker Deacon? Woo! All right, and it looks like Dr. Mujahid is here to talk about some of our patient presentations. And we will do our best to share the microphone to the audience members so those of you at home can listen. Just chuck it over to whoever's next.
Okay, I have another announcement. So yesterday, the federal government actually classified Juneteenth as a federal holiday. For those of you who don't know, Juneteenth kind of celebrates the official end of slavery in the United States. So 1862 was when President Lincoln signed the proclamation. And then it depended on the Union Army to actually make that be enforced. So Texas was the state that was farthest away from the Union, and it was the last one to acknowledge it 2 years later. I think it's a great step for the US right now and just shows us that we're making progress and there's still more to go. Anyway, that's my plug. All right, this first case is from Dr. Kruger. We have a 53-year-old female, past medical history of hypothyroidism and a long-standing history of psoriasis that's mainly limited to her head. She came in with a relatively new complaint within the past year of this redness that is mainly on the posterior and lower scalp, neck, and chest. Although she has these complaints, her psoriasis overall is well controlled, and these current findings aren't consistent with it. She describes it as a non-pruritic and mainly extending behind the ears and also extends down her chest. She's had treatment for this redness with Mirvaso, which for those of you who don't know this brand name, it's bromonidine. Basically, it's alpha agonist, allowing for vessel dilation or constriction, and it's usually used to treat rosacea. So she started this medication August to October to help alleviate the erythema. But then after using it, she did get some resolution of erythema, but kind of centrally to all of her other patches. So she discontinued it, and she did not like the cosmetic appearance of that central whitening, and that has persisted even after discontinuation of the medication. For her psoriasis, she has been on clobetasol, methotrexate, Remicade, and it seems to be very well controlled. Of note, in an office visit in 2020, it seemed that some of the findings of her psoriasis were not consistent with the patient's symptoms. And she had extensive psoriatic patches with minimal itch. She also had COVID, and so did the rest of her family in November and to December 2020. And she also has a history of HSV. Inflammatory labs, ESR, CRP, have been unremarkable. The only significant findings for her CBC show an MCV of 101.7 and a low granulocyte count. So here you can see she has these erythematous patches on her neck, and then here's that central hypopigmentation of the anterior neck. Here's a lateral view of the left, and then a bilateral view of her neck. So Dr. Kruger is interested in knowing your thoughts on what is differential for diagnosis and then treatment. Poikiloderma blushing.
Nevus anemicus was also mentioned. Photosensitivity is sparing in the neck. Throw P. alba in there if you wanted.
When you say poikiloderma, do you mean poikiloderma of Savat or? Yes. So I suppose other types are possible. That's probably the most common. Anyone in the chat have anything to say? Anemicus. Isma asks us not to judge her spelling.
As well.
For the purposes of time, we might have to move on. Any final thoughts about clinical differential? Possibly irritant contact.
All right. Any further workup?
Persistent blanching following Moreso. There's some literature to support that. If that's true, I don't know why, and I don't know how to treat it. Yes, she put Moreso on all of the red area there, and the only area that turned white is this spot. And it's persistent, 3 months after using it. Yes.
Options are to try to make that one red again or make the rest of her skin white again.
Or try to look in the mirror and not see it.
Hello. Dr. Duffin said, I've seen photosensitivity like this in a patient on an anti-TNF.
So if you're trying to make the rest of her neck white, you could maybe do PDL or other cosmetic treatments. Dr. Milliken's nodding in the background. And if you're trying to make the rest of her, or make that white spot red again, I don't know, can you do a topical alpha antagonist? Get something compounded?
Is there anything you can inject into the skin to test that hypothesis?
No idea.
So, as I understand it, this is a alpha adrenergic blocker, is the Moreso. I don't know any way of reversing that.
It's an alpha-2 agonist.
Alpha-2 antagonist.
Agonist.
Agonist, thank you.
I mean, I guess you could take biopsies of the affected and unaffected skin, and I don't know, would that help? Dermatopathologist? No.
It doesn't, so an acquired process that's now become permanent, caused by a drug, yeah.
Dr. Peterson is skeptical that this change is permanent.
So I was skeptical the first time I saw it, and remain skeptical.
Oh, Chris agrees.
Well, 'cause I guess unless it's causing clotting of the capillaries, I guess. I mean, I don't know how else that could be a permanent effect, especially of Mirvesa, which is so temporary. As that's the drawback of the drug, right? Right. So I mean, unless there was thrombosis that was coming from it, I can't imagine permanent from it very well.
Would anyone recommend a biopsy?
A lot of head shakes. Does she have a before picture so we can be sure it wasn't there beforehand?
If you go back to that picture right there, that was a picture that was taken before. And I think I can imagine that there was a hypopigmented spot there.
You're not imagining it.
But
right
we
there.
certainly made that be much more prominent with the Mirvesa.
Maybe the rest of her got worse, as like Decker said. Well, I think we may have to move on to the next case, but I think extremely useful for Dr. Kruger's patient. Thanks, everybody. Any further thoughts? I'm sure you can send messages to him directly.
Homework for next time. Everybody needs to know how to spell poikiloderma.
Oh my gosh.
Everybody must know how to spell poikiloderma of Savant in order to graduate from residency, says Dr. Duffy.
Okay, I'm not ready yet. The next case is from Dr. Hall. This is a case of a 24-year-old female with chronic ingrown nails, pain, and paronychia. This has been going on for several years and seems to be progressive. She has been evaluated by multiple different specialties, including podiatry, hand surgery, and several dermatologists. She also is seeing pain clinic for these nails. The location is including nearly all her fingers and several of her toes. She initially presented to Dr. Hull as a consultation for nail removal and matrixectomy. She requested matrixectomy and nail removal for all 10 fingernails. Partial nail avulsion without matrixectomy was done on 2 nails without any improvement. She's also used oral and topical antibiotics, topical and intralesional steroids, oral steroids, methotrexate, cyclosporin, gabapentin, numbing creams, and she spends several hours per day treating her nails and removing painful ingrown nails. So here you can see she basically has chronic paronychia of nearly all fingers. There's erythema and edema, and she also has these shortened nails with the hyponychium exposed on many of her fingers. So the big question that Dr. Hall had is, what treatment can we use to help this patient?
Everyone says gloves.
That's gloves.
So it sounds like there's some question about some self-induced aspect of this. Was there an antifungal on the list I didn't see? I think sometimes chronic paronychia is due to Candida. Marta would like to see the photo again, everybody. Sounds like Dr. Peterson wonders about a factitial disorder. Is that a fair characterization of what you just said?
Yes, yes.
Very much a component of trauma. She does get, nails red now, but she's for sure. Swelling and there's times when her nails are very red and swollen. That comes and goes, and yeah, the nail plates are all good. They get picked back into the hyponychium, and then you get this huge pain response. And the chief complaint is spicules of nail coming out of the nail folds and having to be removed, or worsened. I did a trial of partial nail avulsions on the two worst, like a thumb and I think the middle or ring finger, and it really didn't do a whole lot. It didn't do a matrixectomy, but it was interesting. Even week or two later, the skin was still just as inflamed and painful with the nail gone.
Doctor.
I mean, she had a good evaluation by the pain clinic, and they discussed a lot of this with her then, and adjusted some of her psychiatric medications. It didn't help much, unfortunately. So it's just been, I've tried basically everything I can possibly think of and haven't had much response. And so mostly just brought her to see if there was something I was missing or some other recommendation that might help her. It's just been this has been a several year situation that hasn't had a lot of benefit from any of our treatments.
Dr. Mathis, oh sorry, Dr. Peter. Dr. Mathis recommended Risperdal. Says several hours of work on the nails sounds suspicious.
Yeah, if this is primarily like a psychiatric thing, like obsessive compulsive picking or something, you could also think about N-acetylcysteine.
Dr. Mathis also says, does she have Candida anywhere else for chronic mucocutaneous candidiasis?
No, but she's on weekly fluconazole because I've also got her on chronic antibiotics because she's had intermittent staph infections. The fluconazole has been going for months. It hasn't done much, but doesn't have any oral and doesn't have any immunocompromising conditions or anything. I haven't worked her up really extensively for that, but she's otherwise healthy.
So, Dr. Hull, do you think the patient will be pleased with us recommending gloves and psychiatric medications? Ask psych to weigh in.
I don't know how helpful an antipsychotic be with, because its OCD is mostly treated with SSRIs, SNRIs. You can do N-acetylcysteine as well. So I would look at those medications rather than an antipsychotic, because there's no, unless she has like psychosis, like she's delusion and she thinks there's bugs or whatever at the nails. It's more of obsessive disorder, and so.
Dr. Hull says she's not delusional and she's on some of those SSRI things. So my impression is that most of us feel that this is largely a self-induced thing. Is that your impression, Dr. Hull, or is that the patient's impression?
Yeah, I mean, it's definitely a tough cycle right now that I'm trying to have an impact on. There's very much I think most of this now is sort of chronic, prurigo kind of pattern, which is trauma and kind of exacerbating the condition. So I think those recommendations will be good. We've discussed those, and she's very amenable to any sort of recommendations. So I can kind of lead her that direction.
All right. It's a little after 9. Any final thoughts before we close out? Dr. Kruger's got one.
A thing that we didn't pick up on for the case that I tried to find literature to support the idea that you can have persistent blanching post treatment. And if you go to a listing of all of the side effects, it's listed as persistent blanching. I can't find any additional literature on that, and I'd be interested if someone has got some insight into that. You can email me. Thank you.
All right. Well, hooray for our first in-person grand round since the pandemic. We'll see you guys on July 9th.
No, because there's now a huge gap. You guys have your business meeting.
Right after.